We go on to our third speaker, Dr. Narendran, who needs no introduction, is the Chief Medical Officer of the Arvind Eye Care Systems based at Coimbatore. And an amazing setup they have, and they are really expanding further, doubling up the space, and that tells us how amazingly they manage the volumes. And he would be talking on outreach program planning and execution. It's just not what they do inside, it's what they do outside, which keeps them at a different level from all of us.
At the outset, I would like to thank Dr. Chitra and members of the ARC for giving me an opportunity to be here today. As an eye care provider, it is important. We all know that what we should do, but it's also important that we should know why we should do. For that, we should have an understanding of the backlog, the gender inequality, the urban versus rural ratio, and also the aging population. Coming to the backlog, it's heartening to see that both blindness and visual impairment is declining over the years. But it's very important that one should understand that the absolute number of people with either blindness or visual impairment is nearly 10.81 crores. Coming to the population, the urban versus rural, we see that around 898 million are still in the rural areas. And these are the people we should cater really through outreach programs. And as far as aging is concerned, we all see that the aging population in India is on the rise. Right now, it's around 267 million of people who are above the age of 50. As far as gender inequality is concerned, we have seen that around 25% more females have either bilateral or unilateral cataracts. And resources, we all know that in India, we have around one ophthalmologist per 70,000 population. And when we compare it with other countries, it is very less. And most of these ophthalmologists are concentrated in the urban areas. So we should need a good planning system for outreach programs, which includes improving our goal setting process. We should also plan and utilize our resources optimally. And it's also important that we reach the unreached, in the sense that we cater to areas where there is an absolute need, where there are no ophthalmologists around. And also, what we should keep in mind the productivity, because any program should be cost effective, and also monitor and evaluate our outreach programs systematically. And lastly, we should continuously improve our patient care services. As far as improving goal setting process, we can set at Aravind have an annual planning meeting as far as outreach program is concerned, wherein we set a target for that next year. This is based on the trend in the annual growth rate, productivity trend analysis like the outpatients and inpatients per camp, lessons learned through previous experience, and also potential that's available weeks per year for the camps, because one should also take into account the festivals, the other local programs. And it's important that one should plan and utilize the resources optimally. Once the goal is set for a year, then we should design the service delivery system, whether we are going to how many cataract camps, or cataract with refractive errors, or comprehensive camps. It's better now to have comprehensive eye care services, because we can tackle both preventable as well as curable blindness. And also, we should plan our resources like manpower, the infrastructure, and supply chain. We should also strengthen the planning process, thereby helping to achieve the goal, to utilize the resources optimally. This is how we potentially staff for the outreach program. For every 150 outpatients, we expect around 40 cataracts, 40 glasses, and we send in a team of 6 staffs. The volunteers for registration are usually sourced from the local area, from the local organizers. For a camp which has we expect an outpatient of 150, we send in one doctor, one ophthalmic nurse, one optometrist, one counselor, one optician, and then one organizer who takes care of the overall coordination. Like I told you, we should reach the unreached. Normally, we have a service area wherein we divide each of the Aravind. We have a service area wherein we cater to around 10 districts from each hospital. We divide the district into taluks, blocks, and also villages. There's a potential of around 300 villages in each block. So we cater to at least see to it that 40 villages are covered through our outreach program. We all, like I already told you, we have an annual planning meeting wherein we set in an annual target. Then we break it into monthly planning, and also we conduct weekly meetings so that we plan for that week. And we also develop appropriate strategies so that we achieve the goal. And effective execution of strategies will increase the productivity per camp. It's very important that it should be cost effective on the long run. The effective planning process and execution, mainly we should focus on productivity. For example, the cost for which we spend for a camp is mostly fixed cost, like publicity, HR, and others. So the productivity is directly influencing the cost effectiveness of the camp, which we normally do not usually calculate or analyze. For example, we normally we spend around 15,000 for pre-camp preparation, awareness, publicity, and campsite logistics, and another 10,000 for medical team, the human resources, transport of the team, outpatient services, and hospitality. So if the camps are really productive, like if you see 60, if you get 60 inpatients, the cost per inpatient works out to around 417 rupees. Whereas in the same camp, if you get around 20 inpatients, then the cost per IP rises to 1,250 rupees. So the as productivity increases, this brings the unit cost down, and we should keep this in mind. And also we should systematically monitor and evaluate all the camps every week. This is mainly a managerial function. We collect a lot of data, but it's very important that you should analyze them systematically. And that's a strategic way to ensure efficient achievement of the outcomes. And we should judge the value of each outreach program. As far as execution is concerned, we should focus on alignment of resources, design the system to complete the service loop, standardize all the protocols, and monitor the output and outcome consistently. Outreach is not just a responsibility of a small outreach team, but everyone in the organization from top to bottom and from bottom to top should participate in it. This is how maybe the video is not working. Normally, this is the outflow of any outreach program. We start with the registration, then after that,
It's not working. You've
not
tried.
working.
You
Okay,
leave it.
then we have the visual acuity measurement, then the preliminary examination by doctors, and based on whether they need a refraction, or if they have we send them for refraction, and if they are ideal candidates for cataract, then we send them for intraocular pressure measurement and duct, and then the final examination by doctors. But it's also very important that now we do an intraocular pressure measurement for everyone above the age of 40. And after the final examination, then we depending on the nature, we advise medication or spectacles, or we refer them to the specialty wherein they go for the counseling and they are asked to come to the base hospital services. If they are advised cataract, then they undergo a blood pressure and blood glucose test. And then we also take a systemic history, counseling, and admission. And these patients are transported to the hospital on the same day and surgery done. And then we go for a 1-month follow-up to the campsite. This is how it happens. Like we do a on-site transport, pre-operative investigations. Once the patient come into the hospital, then the surgery is done. Then they are discharged with post-operative medication, and the follow-up is done after 1 month at the campsite. Last year, we have done in Coimbatore, we have done around 360 camps. We're screening a total of around 76,700 patients, and we got an average inpatient of 81. Apart from these comprehensive camps, we also have some specialty camps like diabetic retinopathy screening camps, which are done regularly. For want of time, I'll just go through this. And then this is the number of camps which we did last year. And then we also conduct workplace camps. For example, we identify industries which have a sizable number of workers above the age of 40, and then we do these camps so that they need a presbyopic glasses, and studies have found out that the productivity of that worker has gone up many times after the camps. These are the school screening camps where we train the teachers on how to check for refractive errors, and then they go back to the school. They examine the children, identify children who need examination by an optometrist or an ophthalmologist, and then the team goes to the school and screens them. And this is a recent one wherein we started screening also for retinopathy of prematurity, which we started in the year 2015, wherein we had screened close to 38,000 babies. And these babies, we saw that around 7% of them needed some form of treatment. Also, we should also keep in mind that we should continuously, there should be continuous improvement in patient care services in the form of social auditing, internal auditing, and clinical auditing. So to conclude, outreach programs for any outreach program, we should have an exclusive team with clear role clarity and accountability. It's a top to bottom initiative, and they need continuous support. But when it comes to action, it is a bottom to top plan. And you should have a systematic way of goal setting and standard protocols and robust system to monitor the performance. Thank you.
Thank you, sir. Thank you very much for that one.